So for today, we're going to be talking again about chapter 11. And when we're talking about chapter 11, we're going to be focusing on eating disorders. As we are focusing on eating disorders, there is a number of things that we are going to be able to do by the time that we are done. We are going to be able to list the central features of anorexia and bulimia, and we're also going to be able to discuss the age groups in which anorexia and bulimia are most common. We're going to compare and contrast the various behavioral patterns of anorexia and bulimia because there is some overlap, but there are also distinct differences. We're going to look at medical problems that can be caused by each of the major eating disorders. We're going to explain how each of these factors can place a person at risk for an eating disorder, including ego deficiencies, cognitive factors, mood disorders, biological factors, societal pressures, family environment, racial and ethnic differences, as well as gender differences. We're going to look at treatment for anorexia nervosa, including weight restoration and resumption of eating, and discuss some broader psychological changes in the aftermath. We're going to also do the same thing for bulimia, including individual therapy, group therapy, behavioral therapy, and antidepressant drugs, as well as discuss the aftermath of bulimia. And then finally, look at binge eating disorders, its symptoms, and treatment options. When we look at eating disorders overall, we are looking at a number of things. So before we even go into this, while it hasn't always been the case, Western modern society will equate thinness with health and beauty. In fact, in the United States alone, thinness has become a national obsession. Most of us are preoccupied with how much we eat, as with the taste and nutritional value of our food. So it's not surprising that during the past 30 years, we've witnessed an increase in eating disorders. And the three main eating disorders, and the ones that we're going to talk about in today's session, is all about anorexia nervosa, bulimia nervosa, and binge eating disorder. The core issue with both anorexia nervosa and bulimia nervosa is an intense fear of gaining weight. These two eating disorders are associated with a number of serious medical complications. Binge eating disorder also appears to be increasing in prevalence. While individuals with binge eating disorder don't fear gaining weight like persons with anorexia or bulimia, many features of binge eating disorder are similar to those of the other two eating disorders. So, what is exactly an eating disorder? Well, an eating disorder, even though it has become some type of a national obsession, it typically has to do with the relationship with food. And not only the relationship with food, but how that impacts one's body of either the fear of gaining weight or the fear of not being thin enough. So in looking at anorexia, there's a couple of things that we have to keep in mind. For many of these individuals, they purposely take in too little nourishment, which results in poor body weight that is low and below that of other people of similar age and gender. Individuals are extremely fearful of gaining weight or repeatedly seek to prevent weight gain despite their body weight. As such, individuals have not only a distorted body perception, they place an inappropriate emphasis on weight or shape in judgments of themselves or fail to appreciate the serious implications of their low weight. So when we think about anorexia, let's talk for a second about some backgrounds. For many of these individuals, the main symptoms of anorexia nervosa are typically a refusal to maintain more than 85% of their normal body weight, an intense fear of becoming overweight, and distorted view of their weight and shape. There are two main subtypes. One is the restricting subtype, and the other is the binge eating and purging type. In the restricting type, they lose weight by cutting out sweets and fattening snacks, eventually eliminating nearly all food. With the binge eating and purging type, they're going to lose weight by forcing themselves to vomit after meals or by abusing laxatives or diuretics, which force their body to expel out any food or liquid or fat that's there. Similar to bulimia nervosa, people with this subtype may engage in eating binges. It's not uncommon. When we are looking at the progression, it's normal to slightly overweight female that's typically been on a diet. There's also an escalation towards anorexia nervosa that can follow a stressful event, and one of the things that a lot of psychologists are looking at today, especially in light of everything that is going on in our current society, they're seeing if there's a higher rate of anorexia nervosa because of all the stressors that are happening socioculturally. And finally, whereas most people do recover, as much as 6% will succumb to this. And when I talk about succumbing to this, I talk about death. So when we are thinking about this, there's a couple of things to note. That, first of all, approximately 75 to 95% of cases will occur in females. The peak age of onset is typically between 14 and 18 years of age. Around 0.5% to 4% of females in Western countries will develop anorexia nervosa at some point in their lifetime. Many more will display at least one symptom of this disorder. The rates of anorexia nervosa, they are drastically increasing in North America, Europe, and Japan. In addition, and adding to this clinical picture, is something that we look at as something of a typical case. So again, normal to slightly overweight. Stressful events can include the separation of parents, moving away from home, experiencing some type of personal failure. But also in building on this clinical picture, there's the overarching goal for people with anorexia nervosa to becoming thin and staying thin. The driving motivation is typically fear of either becoming obese, of giving into the desires to eat, or of losing control of their body size and shape. Despite the dietary restrictions, people with anorexia are preoccupied with food, and this includes thinking and reading about food and planning for meals. And the preoccupation with food may be a result of the disorder. So when they've looked at different studies, they have found that participants in this starvation study conducted with conscientious objectors in the 1940s found similar preoccupations with food and eating even today. Persons with anorexia nervosa think in distorted ways. They usually have a low opinion of their body shape. They tend to overestimate their actual proportions, even when looking at a photo of themselves while making judgments. And many hold maladaptive attitudes and misperceptions like, I must be perfect in every way. I will be a better person if I deprive myself. And I can avoid guilt by not eating. People with anorexia may display certain psychological problems, and that's going to include things like depression, anxiety, low self-esteem, insomnia or hypersomnia, substance abuse issues, obsessive compulsive patterns, and perfectionism. They're also going to have medical problems. Often people with anorexia are susceptible to certain medical problems that's caused by starvation, including amenorrhea, low body temperature, low blood pressure, body swelling, reduced bone density, slow heart rate, metabolic and electrolyte imbalances, which can lead to heart failure or circulatory collapse, dry skin, brittle nails, poor circulation, and luongo. Now let's talk about bulimia. So some background on bulimia. Bulimia nervosa is also known as the binge-purge syndrome, and it's characterized by binges, which are repeated bouts of uncontrolled overeating during a limited period of time. The disorder is characterized typically by inappropriate compensatory behaviors like forced vomiting, misusing laxatives, misusing diuretics, or misusing enemas, fasting, and exercising excessively. For many of these individuals, they will have repeat binge episodes and repeat these behaviors to prevent weight gain. Most of the symptoms will take place at least weekly for a period of 3 months or more, and they're going to have low self-concept and very low body image. With anorexia nervosa, approximately 75 to 90% of bulimia nervosa cases are in females. The peak age of onset is between 15 and 20 years of age. Symptoms may last for several years with a periodic let-up. So they'll engage in this for years and then stop for a short period of time. Patients generally are of normal or near normal weight, but some will experience significant fluctuations in their weight, like weight gain during binges and weight loss during purges. Some may become significantly underweight and eventually qualify for a diagnosis of anorexia. The quote-unquote typical case of bulimia nervosa is a normal to slightly overweight female that is on an intense diet. Research suggests that among normal patients, binging often occurs after strict dieting. So here is just a little bit of an overlapping pattern of anorexia, bulimia, and obesity. And this is really important to discuss, because if we look at this overlap here, where the normal weight bulimia nervosa disorder is in the yellow, we can see that restricting and binging often will have this, overlap, that there are many similarities and fluctuations in and out of anorexia and bulimia, and between bulimia and being normal weight or overweight. And that type of fluctuation can cause body distortions as well as self-identified distortions, which is often what you see in eating disorders. When we talk about binges, many teenagers and young adults will go on occasional binges or experiment with vomiting or laxatives after hearing about these behaviors from friends or within the media. When we are talking about them and what they actually are, some things to think about is that when you look at different studies, global studies, about 25 to 50% of students report periodic binge eating or self-induced vomiting, which is a lot. Only some of these individuals will actually qualify for a diagnosis of binge eating disorder or bulimia nervosa with binging episodes. People with bulimia nervosa may have between 1 and 30 binge episodes per week. So binges are often carried out in secret. There's rapid consumption of massive amounts of food with little chewing, usually sweet, high-calorie foods with a soft texture. Binge eaters commonly will consume between 2,000 and 3,500 calories and as many as 10,000 calories per episode. Binges are usually preceded by feelings of great tension, including shame and guilt. And while the binge itself might be pleasurable, those extreme feelings of tension then lead into self-blame, depression, fear of weight gain, fear of being discovered, and even more, shame and guilt. After a binge, people with bulimia nervosa try to compensate for and to quote unquote undo this caloric effect by vomiting, using laxatives, using diuretics, or excessively exercising. So many will ultimately resort to vomiting, because when you think about vomiting, this will fail to prevent the absorption of calories that were consumed during a binge, even up to half of the number of calories that were consumed. Repeated vomiting will affect the ability to feel satiated, leading to greater hunger and frequent and intense binging. Also, compensatory behaviors may temporarily relieve the negative feelings attached to binge eating, but over time, there's going to be a cycle that develops in which purging leads to binging, and binging will then lead into purging. So you'll go through purging and binging and purging and binging. So bulimia nervosa and anorexia nervosa, as stated earlier, there are similarities as well as differences. So let's look at the similarities. So typically it begins after a period of dieting. There's also a fear of becoming obese, a strong drive or desire to become thin, preoccupations with food, weight, and appearance, feelings of anxiety, depression, obsessiveness, and perfectionism, heightened risk of suicide attempts, substance abuse, distorted body perception, and distorted attitudes towards eating. But again, there are differences. People with bulimia are more concerned about pleasing others, being attracted to others, and having intimate relationships than someone with anorexia nervosa. People with bulimia tend to be more sexually experienced and active. People with bulimia are more likely to have histories of mood swings, low frustration tolerance, and poor coping. So, i.e., they have no coping skills or very little coping skills. More than 1/3 of people with bulimia are likely to display characteristics of a personality disorder, primarily borderline personality disorder. They also have different medical complications. Only half of women with bulimia experience amenorrhea versus all women with anorexia who will experience amenorrhea. People with bulimia will suffer physical damage that's caused by purging, especially from vomiting and laxatives, such as tooth loss or intestinal disorders. Not fun. Now, let's look for a second at body dissatisfaction. This is the single most powerful contributor to dieting and the development of an eating disorder. People who evaluate their weight shape and who evaluate their weight and their body shape negatively are often experiencing what's called body dissatisfaction, which can lead to issues with body image. Approximately 73% of all girls and women are dissatisfied with their bodies, as compared with 56% of all boys and men. So what does that say from a sociocultural perspective of how we emphasize or de-emphasize what it means to be attractive, and we tie in our attractiveness with our value and our worth? The vast majority of dissatisfied females are believed that they are overweight. And when you think about it, half of the dissatisfied males consider themselves overweight and half consider themselves underweight. So there really is no such thing as normal or common. Now let's talk about binge eating disorder. Like those persons with bulimia, individuals with binge eating disorder engage in repeated eating binges during which they feel absolutely no control. These individuals don't perform inappropriate compensatory behaviors, and as a result of their binges, about 65 to 70% of people with this disorder will become overweight or obese. Most overweight people don't engage in repeated binges. When we are looking at this, we are essentially taking a look at how these factors that we are seeing, the fast eating, the absence of hunger, the uncomfortable fullness, secret eating due to shame, and feelings of self-disgust, depression, and severe guilt, they are very significant in binge eating disorder. You also find it in binge eating episodes of bulimia nervosa. Typically, when you're looking at binge eating disorder, there is significant distress that can impact a person's ability to engage in their in significant relationships, as well as an issue in things like their occupation, as well as school. Binge eating episodes will take place, again, like anorexia and bulimia, for at least weekly over the course of 3 months. And again, that absence of compensatory behaviors. When we are thinking about this, these repeated eating binges, the lack of control is huge. Approximately 2 to 7% of the population display this binge eating disorder. The binges and many other symptoms that characterize this pattern are similar to those seen in bulimia. Persons with binge eating disorder are not driven to thinness, as the disorder doesn't start following a diet, and the gender differences in the prevalence of this disorder are not as large as those with bulimia. Something to take into consideration is that binge eating disorder was not a diagnosable disorder until 2013, when the DSM-5 came out. The practice of the DSM-5 was not universal until 2015. So in the last 5 years, we are now seeing a rise in the number of binge eating disorder patients, but we don't really know the full ramification of binge eating disorder because it is still a new term, and not everyone who has an eating disorder or binge eating patterns have been either diagnosed appropriately. They might have been diagnosed as bulimia nervosa with binge eating patterns, or they're not seeking support for their binge eating disorders. Therefore, they don't have a diagnosis. So this is just a comparison of eating disorders and the prevalence. I want you to take a look for a second at the 1-year prevalence for binge eating disorder. It's a pretty high rate, and it affects a lot of females, not as many as anorexia or bulimia, but again, still, we are waiting for a lot of these results. Typical age of onset for anorexia and bulimia is high school into early college, whereas for binge eating is typically post-college into and through early adulthood. So overall, what causes eating disorders? Most theorists and researchers use a multidimensional risk perspective to explain eating disorder. There are several key factors that place an individual at risk. The greater the number of factors that are present, the greater the likelihood of developing an eating disorder. Some of these leading factors include psychological problems, biological factors, and sociocultural conditions. But it can also include family environments, as well as cognitive behavioral or learned behaviors. When we look at psychodynamic factors, This ties into ego deficiencies. So Hilda Bruch developed a large psychodynamic theory of eating disorders. Bruch argued that eating disorders are the result of disturbed mother-child interactions, which lead to serious ego deficiencies in the child and severe perceptual disturbances. Bruch also argues that parents may respond to their children either effectively or ineffectively. And effective parents will accurately attend to their child's biological and emotional needs, including feeding the child when they're hungry, comforting the child when they're scared. Ineffective parents will fail to attend to a child's needs or incorrectly assess the child's needs. They'll feed when the child is anxious and they'll comfort when they're tired. So as this happens, these children may grow up confused and unaware of their own internal needs and in turn look to external guides, including people and food. There are also a number of clinical reports and research that have provided some empirical support for Bruch's theory. Individuals with eating disorders have difficulty identifying their emotions. Sometimes we call this alexithymia. And they also worry about how others view them and often seek external approval and also lack a sense of control. So this figure here in 11.2 from our book looks at when do people seek junk food. Look at the highest rate right now at boredom, which is 69%. A lot of people may be experiencing that right now, especially in light of everything that's happening. So it goes to show that some people, if they don't have adequate coping skills and if they lack the ability to control themselves, that they may seek junk food as a way to deal with boredom. Or they may, yeah. So now let's look at a cognitive behavioral factor. So Bruch's theory also contains several cognitive behavioral factors, such as improper labeling of internal sensations and needs. So according to the cognitive behavioral theorists, these deficiencies contribute to a broad cognitive distortion that lies at the center of disordered eating. For example, people with anorexia and bulimia judge themselves negatively based on their body shape and weight. Then we have depression. Many people with eating disorders, particularly those with bulimia nervosa, experience symptoms of depression. Theorists believe that depressive disorders may, quote unquote, set the stage for eating disorders. So there's empirical evidence to support this model. Many more people with an eating disorder qualify for a clinical diagnosis of major depressive disorder than people in the general population. Close relatives of individuals with eating disorders seem to have higher rates of depressive disorders. People with eating disorders, especially those with bulimia nervosa, have serotonin abnormalities. Symptoms of eating disorders are helped by antidepressant medications in many ways. And of course, symptoms of depression could be a consequence of an eating disorder rather than a cause. When we look at biological factors, biological theorists suspect that certain genes may place some people at an increased risk of developing the disorder. Hold on 1 second. So, where were we? When we look at biological factors, there are biological theorists that suspect that certain genes may place some people at an increased risk of developing certain eating disorders. So, relatives of people with eating disorders are up to 6 times more likely to develop the disorder themselves. When we look at identical twins with anorexia, they have a 70% concordance rate. Fraternal twins have only a 20% concordance rate. That's huge. A lot of identical twins with bulimia have a 23% concordance rate, whereas fraternal twins only show a 9% concordance rate. These findings may be related to dysfunctional brain circuits. So when we think about this, we're looking at regions in this circuit that include the insula, the orbital frontal cortex, the strainium, and the prefrontal cortex. Neurotransmitters that are involved include serotonin, dopamine, and glutamate. But there's also other theories that our eating disorders may be related to dysfunction of the hypothalamus. Researchers have identified 2 separate areas that control eating. That is the lateral hypothalamus and the ventromedial hypothalamus. Recent research has identified that there's also a glucagon-like peptide 1, GLP-1, that's naturally occurs as an appetite suppressant. Some of these theorists believe that the hypothalamus related to the brain area and chemicals together are responsible for a weight set point. That is a weight thermostat of sorts. So when you look at the genetic inheritance and early eating practices, this mechanism is responsible for keeping an individual at a particular weight level. If the weight falls below the set point, hunger increases while metabolic rate decreases, leading to binges. If weight rises above that set point, hunger decreases while metabolic rates increase. So think of it from this perspective. Dieters will end up in this battle against themselves to lose weight, which is one of the main reasons why people who are dieting tend to not have long-term success with their diets. Now let's look at some social pressures. Many theorists believe that current Western standards of female attractiveness are partly responsible for the emergence of eating disorders. Western standards have changed throughout history, and in the last 60 years there's been a huge shift towards this thinner ideal. So an example is Miss American contestants. They have steadily declined in weight over this time. Playboy centerfolds have a lower than average weight, bust, and hip measurements than in the past. Members of certain subcultures are at greater risk from these pressures, such as models, actors, dancers, and certain athletes. Of college athletes that have been surveyed, about 10% meet the full criteria for an eating disorder, while another 33% displayed symptoms. Approximately 20% of gymnasts appear to have an eating disorder. So, social attitudes help to explain some of these things. They also help to explain economic and racial differences that are seen in the prevalence rate. So, historically, women of higher socioeconomic status expressed greater concern about thinness and dieting. They also had higher rates of eating disorders as compared to women with lower socioeconomic statuses. Also, there's been dieting and preoccupation with thinness, along with rates of eating disorders, that's been increasing in all groups. So when we think about this, socially accepted prejudice against overweight people may add to the fear and preoccupation about weight. Prospective parents will look at chubby infants as less intelligent, friendly, and desirable than photos of medium weight or thin infants. There's also been a recent survey of adolescent girls that tied eating disorders and body dissatisfaction to social networking, internet activities, and television, which leads us to this dark side of the internet. When you think about this, most of disordered eating patterns are as a result of what we see on the internet. But what many girls and women, or people in general, tend to not think about is that the images that you see on the internet are typically altered. It is estimated that up to 90% of photos that you see online have some type of retouching that has been done, or that they have filters applied to them to look thinner, to look younger, or to accentuate certain body parts. So when people are looking at these images, they're not real images. So they are comparing themselves to something that is not accurate and not real and not a true representation of what is happening in the larger society, not only in the United States culture, but also the global society. We also have to look at families. Families may play an important role in the development of eating disorders. As many as half of the families of individuals with eating disorders have long histories of emphasizing thinness, appearance, and dieting. Mothers of persons with eating disorders are more likely to be dieters and perfectionists themselves. Abnormal interactions and forms of communication within a family may set the stage for an eating disorder. So there was this family theorist, his name was Salvador Minuchin. He essentially says that enmeshed family patterns is a causal factor of eating disorders, and these patterns include over-involvement and over-concern in the details of family members' lives. We also have to look at multicultural factors, because there are not only gender differences, but there's also racial and ethnic differences. So something for us to think about is that there's definitely different ideals of what it means to be beautiful. Males account for only about 10% of all cases of anorexia and bulimia. based on this ideal beauty, which means the majority of cases are female. The reason for the striking difference is not entirely clear, but Western society's double standards of attractiveness is, at least at best, one of those reasons. There may also be a second reason, which is where men are more likely to exercise and women often diet more. And as we just talked about, diet set people up to fail. Some men's risk of developing eating disorders reflect the requirement and pressures of a job or a sport. The highest rates of male eating disorders are typically found in jockeys, wrestlers, distance runners, bodybuilders, and swimmers. For other men, body image appears to be a key factor. Some men seem to be caught up in this new kind of eating disorder, which is the reverse anorexia nervosa, or muscle dysmorphobia. When we look at racial and ethnic differences, we have to think about this for just a second. Oh, I spelled that wrong, y'all. There's been a widely publicized 1995 study that found that eating behaviors and attitudes of young African American women were more positive than those of young white American women, with nearly 90% of white American respondents dissatisfied with their weight and body shape, as compared to approximately 70% of people who were Black identified. The study also suggests that groups had different ideals of beauty. Non-Hispanic white teens saw thinness as the key to happiness and popularity, whereas Black teens emphasized personality rather than appearance as the ideal. Research conducted over the past decade suggests that body image concerns to functional eating patterns and eating disorders are on the rise among Black women, as well as among women of other minority groups. And this shift appears to be particularly related to acculturation. Eating disorders among Latina women are about equal to those of white American women, especially among those young women who are more oriented towards non-Hispanic white American culture. Eating disorders also appear to be on the increase among young Asian American women and young women in several Asian countries. So now that we have this, how are eating disorders treated? Well, eating disorder treatments have two main goals. One is to correct dangerous eating patterns, and two, to address the broader psychological and situational factors that have led to and are maintaining the eating problem. This often requires participation of family, friends, and loved ones. When we look at treatments for anorexia, approximately 1/3 of individuals with anorexia receive treatment. The immediate aims of treatment for anorexia nervosa are to regain lost weight, recover from malnourishment, and eat normally again. In the past, treatment occurred in a hospital setting, but today it's offered in day hospitals and outpatient settings. In life-threatening cases, clinicians may need to put in a feeding tube and intravenously feed the patient. And this may breed distrust in the patient and create a power struggle. One popular approach combines supportive nursing care with nutritional counseling and a high-calorie diet. Another approach is to use what's called motivational interviewing. This is a strategy that combines empathy with inquiry to help clients recognize in themselves the seriousness of their disorder and commit to positive changes in eating behavior. When cognitive behavioral weight restoration approaches are used, clients monitor their food intake, they will monitor their feelings, they'll be able to better identify hunger levels, while therapists will encourage this healthy way of experimenting control, better awareness of internal states, and more appropriate attitudes about weight and eating. Cognitive behavioral techniques have been empirically shown to be more effective than most psychodynamic therapies, psychoeducation, or support therapy alone. Something else to think about too is that we also need family involvement. Family therapy is important for anorexia because the main issue is often around separation and establishing boundaries. The use of this combined treatment approach has greatly helped people with anorexia nervosa. Even with combined treatment, recovery is difficult. The course and outcome of this disorder will vary from person to person, but some positives of treatment. Typically, it's weight gain that's often quickly restored. As many as 75% of patients still show improvements after several years. Menstruation will often return. with the return towards normal weight, the death rates from anorexia seem to be falling. But we also have to talk about some of the negatives. As many as 25% of patients will remain troubled for years. And even when it occurs, recovery is not always permanent. Anorexic behavior will typically recur in at least 1/3 of recovered patients, usually triggered by some type of new stress. Many patients will still express concern about their weight and their appearance. There's also lingering emotional problems that are common in about half of those with anorexia nervosa. And finally, the greater the amount of weight lost and the longer the duration of the illness, the poorer the prognosis is for an individual with anorexia nervosa. So let's talk about treatments for bulimia. More than 40% of persons with bulimia nervosa will receive some type of treatment in their lifetime. And treatment is often offered in eating disorder clinics because the immediate aims of treatment for bulimia nervosa are to eliminate binge purge patterns, establish good eating habits, and eliminate the underlying cause of bulimic patterns. For many of these programs, they will emphasize education as much as therapy. Cognitive behavioral therapy is particularly helpful in several ways. So let's first look at the behavioral techniques and then the cognitive techniques. So for the behavioral techniques, they will often use diaries as a useful component of treatment, as well as exposure and response prevention, which is used to break the binge purge cycle. For cognitive techniques, they will help clients to recognize and change their maladaptive attitudes towards food, eating, weight, and shape. And typically, they will teach individuals to identify and challenge their negative thoughts that essentially precede the urge to binge. If clients don't respond to cognitive behavioral therapy, there's other approaches that could be tried. A common alternative is called interpersonal psychotherapy, and that is treatment that seeks to improve interpersonal functioning. Psychodynamic therapy has also been used. That's where you go to the underlying issues of what has happened and try to bring that that's been in the subconscious to the preconscious and then eventually to the conscious. The various forms of psychotherapy are often supplemented by family therapy and may be offered in either individual or group therapy format. Group formats provide an opportunity for patients to express their thoughts, concerns, and experiences with one another, and can be somewhat helpful in as many as 75% of cases. We also have antidepressant medications. Over the last 15 to 20 years, all groups of antidepressant drugs have been used in bulimia treatment. Drugs can help as much as 40% of patients to help reduce their frequency of binging and purging. Medications are best when used in combination with other forms of therapy. If left untreated, bulimia can last for years. The treatment provides immediate significant improvement in about 40% of cases. An additional 40% of patients show moderate responses. Follow-up suggests that about 75% of patients have fully recovered or partially recovered after 10 years of treatment. But relapse can be a significant problem even among those who respond successfully to treatment. Relapses are, number one, most often triggered by stress. Relapse is more likely when a person with a longer history of symptoms, who vomited frequently, who had histories of substance use, and who have lingering interpersonal problems. In about 45% of individuals with binge eating disorder, they will receive some type of treatment. Given the key role of binges in both bulimia and binge eating disorder, treatments are often similar in both types of disorders. So we will typically use cognitive behavioral therapy, other forms of psychotherapy, and in some cases, antidepressant medications to reduce or eliminate binge patterns and to change disturbed thinking. People with binge eating disorder who are overweight may require additional intervention, including things about food, their relationships with food, as well as nutritional information. Now that binge eating disorder has been identified and is receiving an influx of empirical studies, it's likely that specialized treatment programs will emerge. In the meantime, there's little known about the aftermath of this disorder. Something else we need to think about too is that there's shame on people who body shame. So this is something that's been noted since the mid-19th century, but looking at the internet, especially social media, this has provided a larger platform for these cruel comments of people that I like to call keyboard warriors than ever before. 94% of teen girls and 64% of boys have experienced some type of body shaming in the last 12 months. Those are alarming statistics. There's also been this counter trend that's been led by influential celebrities that's raising awareness where they are shaming the body shamers. But when we do that, we're not being helpful, we're actually being hurtful, and it hurts the body shamers who then in turn act out on people whose bodies look different. So that cycle will continue. Something else I want to talk about, if we can go back here for a second. When we think of the future, I want us to think about this for just a second. While there has been some support and while there has been treatments that have shown improvements, many individuals don't achieve full recovery with eating disorders. And as I said in the beginning of this lecture, that the worst case scenario is death. There are some people who have argued that more work must be done to not only treat eating disorders, but to prevent eating disorders from developing in the first place. So one of the projects that is out there that's actually pretty popular is called the Body Project. This is a prevention intervention model that helps young women identify Western society's ultra thin ideal and engage in activities that are aimed at body acceptance. That so far has been something that has been super helpful.